Next, I'd like to invite Emma Merry to come and talk. Emma is one of two New Zealand Jules-trained intensive care specialists and palliative care medicine specialists. She works at the Hawke's Bay. I'm personally indebted to her for giving me a job in Wellington in 2002. She recently had occasion to stay with my family last week, and my daughters reviewed her as being both exciting and fun, which I see is now her Twitter bio. So I'd like to introduce Emma Merry based on the words of my daughters. Thank you.
Thank you, Alex. You know you've arrived when a 7-year-old and a 9-year-old think you're cool. So I'm occupying the traditional place for palliative care, which is the end of the last day of any conference. We're okay with that. I'm going to talk with you a bit about some missed opportunities for goals of care. But before I do that, I'd just like to acknowledge the immense amount of experience and wisdom and enthusiasm that I've heard over the past couple of days. I've reconnected with people I haven't seen for a long time, and it's actually been quite a wonderful experience. So, as Alex said, my main role at the moment is palliative care physician, but I do have a foot still in the acute care world. This is the sign that greeted me when I checked into my hotel in Hobart. They weren't quite clear on who I was, so that's why they were covering all their bets. So I thought I'd just try and make it clear at the beginning of every talk that I do who I am now. So that was quite useful. And apologies, I always thought this was original Cerides quote, but it turns out that Will Cairns is responsible. So 2 weeks of intensive care can save an hour of difficult conversation. And that's something that stuck with me ever since I heard it. So I'm going to ask a series of questions first. If you have answers, please feel free to shout them out, but you may not. So you may ask yourself, why is goals of care and treatment important? And I think we've heard a lot of evidence and information to answer that question already. We're probably closer to answering this question than we were before. What are goals of care and treatment? That's going to vary from person to person and patient to patient. Excuse me. Something that I struggle with particularly is how we make sense of non-medical goals as expressed to us by patients and families. How do we translate that into our biomedical model, which is still that reductionist binary question, would you like CPR or would you not? So that's something that we all struggle with, I think. And what if the goals are unrealistic? Sometimes that happens. I was recently at a training course to learn how to train trainers to teach the serious illness conversation guide, which I know some of you are already using. And one of the scenarios we had there was someone who had significant respiratory failure and recurrent admissions with exacerbations. And one of their expressed goals and wishes was to do at least one more of the great walks, which I don't know if you know, they're probably quite long and quite difficult, and some of them have mountains in the middle. So it wasn't really a realistic goal for this person in this scenario. Who should think about goals of care and treatment? And as Anne and Jonathan said yesterday in their communication workshop, I think we all should be. We all should know what we would want in the event of a deterioration. We all should be thinking about what our priorities are. And the perennial question for all of us, how are these plans recorded? Where are they recorded? Who can see them? Can you see them at 2 a.m. when a patient comes to ED? Spoiler alert, no, not usually. So some challenges for goals of care. Firstly, it's really difficult sometimes to acknowledge that a condition that a person has is life-limiting. That can be really threatening to hear or to deliver that news. We also know that diagnosing dying is harder than diagnosing death. Diagnosing death is actually pretty easy. That is really binary. But diagnosing dying is hard. You know, deteriorating retrievable patients look quite similar to dying patients. We know that frequently treatment is offered and given which is not wanted by the person and not warranted. We do know, from my own experience and from yours too, that these conversations are either deferred, it's not my responsibility, I'm too busy, it's not my job, or just plain avoided. So what do we know for sure? We know a few things for sure. We know that being admitted to a hospital takes a toll, especially if you are frail to start with. And deconditioning happens really, really quickly, within hours. That amazed me when I heard that. We know that ICU stay has an impact on both the patient and their family, and we need to remember their context. As we've heard, 1 in 5 patients at least has a palliative care need, but this is often not recognised or acted on. And end of life can be unrecognised until a rapid response team call is made. All of this is not just me standing here speaking. This is distilled wisdom from many wise people who've written papers, as is this. So one of the trainers on the course I did, Rochelle Bernacki, is well known in the palliative care field, and we got to learn from her and her colleague. And when looking at inadequate communication, there are some fairly significant consequences for us, for patients, and for whānau. Quality of life is worse if you stuff it up. Anxiety and distress escalate. Dying can be prolonged. People get things they don't want. They don't trust us anymore. We've heard a bit about trust today. There's often what the American team phrase as resource-patient mismatch, which I think is quite a nice little phrase for doing things to people they don't want to have done to them, and physician burnout, which we're all hearing more about in all the professions now. So this is not a surprising slide to any of you who work in health, or in fact are humans living on the planet. Everything is getting more complicated now. There's no such thing as a person who comes into hospital with one medical problem. Everyone has multiple problems and multiple psychosocial issues. It's actually surprising when someone simple comes across our knowledge. Frailty is increasing in the population, and I love the way that David described it as it's not a problem, it's a challenge. I like that reframing. People are sicker, they're frailer, they're older. It's harder to diagnose dying in older patients. And we're seeing a huge burden of non-malignant disease with different illness trajectories that are unpredictable. And I can't remember the exact phrase that Alex used. I think it was an advanced dwindle, was it? Or accelerated dwindle. Something like that. Something dwindle, anyway. And thank you. We also know that the treatments we can offer people have different impacts, and they sometimes cause a greatly increased life expectancy. People generally are less fatalistic than they were a generation or two ago. So that's some of the context within which we're working. And none of this is a surprise to any of you either. You know, when we were practicing using the Serious Illness Conversation Guide last week, this is not a paid advertisement, by the way, I'm just using it as an example. We found that using that specific tool to structure the conversation actually took about 12 minutes. So people think that these conversations take hours, and sometimes they do, but actually you can have a very useful exchange of views and understanding in a very short space of time. Although we do need to support the people who are having these conversations and train them to do so safely and comfortably. Often, the people who are having these conversations in the middle of the night don't really have an understanding of the impact of the treatments they're talking about on the people in front of them. So they may not know what the outcomes from intensive care multi-organ support are. And so they're being placed in a position where they're having to describe those things to others who don't understand them either. And sometimes we just plain ask the wrong question. Can I have a show of hands from everyone who's ever heard said, do you want everything done? Has anyone ever heard that? Oh, so totally depressing. So we are asking the wrong question of people. We should not be asking them, do you want everything done? For the person in front of us, we don't know what a good outcome looks like for them. We don't know what their goals and aspirations and wishes are. And people are very variable. So when we say to a person, do you want us to do everything? All of these things might be going through their mind. They might be thinking, well, if I say, no, I don't want you to do everything, you're not going to do anything and you're going to give up, and then it's all going to be terrible and I'll have pain, and there's a great fear of abandonment. There's often anxiety. I'm afraid of dying. You know, if you don't do everything, I'm going to die immediately, and that's terrifying. Sometimes people just don't understand how sick they are, and I think that's our failure because we haven't helped them understand that sooner. And then there's a group of people who really do value life above everything. They want quantity, and they're not that worried about quality. And we can all think of people who fulfill that for us. So if we say do everything as a team, that means that we do everything that is technically possible, even if it's not going to work. So all the machines, all the bells and whistles, all of the medications that we can use to support a person. And in most centres, what that means is referral for multi-organ support in an ICU or HDU. Whereupon we start considering what life-sustaining treatments can offer. And these come with risks and benefits. As a colleague of mine once said about almost anything you asked him, he would say, well, it's complex, multifactorial, and varies from patient to patient. That's Forbes Bennett, for those of you who know him. And he's right. That's how we could describe the risks of intensive care treatment. What we're trying to achieve, though, is to get the person back to a state that they would be happy with, and that's consistent with what their goals are. I'm not going to talk about the risk of unacceptable badness, but I'd be happy to answer questions later in the interest of time. So I have 3 examples of people, and I'll just go through them briefly. So John was a patient in his 70s. He had significant heart problems, significant kidney problems, significant lung problems, and he kept coming into hospital with infections in his urinary tract. He'd had a history of cancer, and in the past 40 months, he'd spent 149 days of that in hospital. Not all at the same time, but bit by bit. On his final admission, John came in with shortness of breath. He had a VF arrest in the emergency department and was resuscitated and then transferred to ICU, where he died on full support. And I have a little image of his trajectory down there. So to me, the issues with John and his care were that there was no long-term plan and no overall view of what was happening to this man. It was quite predictable that he would follow that course, but there was no evidence of a plan. There was no real documentation, and EDS means electronic discharge summary, which is the thing that you get every time you leave hospital, for those of you who don't know. And that never is a true reflection of what has happened during that admission, ever. There was no real evidence of an interface between how he was being cared for in his community context and what was happening in the hospital, and there were heaps of people involved of all different specialties, but no unified approach. So what did he need? He needed a conversation. He needed to know what to expect, he needed it to be written down, and he needed people not to miss all of these opportunities for this conversation to happen. Brenda will ring some bells for my Hawke's Bay colleagues. She was a lady in her 60s with severe lung failure. She came in for a planned abdominal hernia operation, and she was referred to high dependency afterwards, after the surgery, with respiratory failure. She had a long intensive care stay, and she eventually got off support at day 91 after an elective operation. So the issues here with Brenda were that she spent such a long time on the waiting list that her lungs had a chance to really deteriorate before she actually got into hospital to have the operation. Should she have even been offered the operation? Did she have a chance to actually make an informed decision? There was no discussion with ICU teams prior to the operation being planned, and we might have had something to say about it at that point. Also, if she had come in as a planned admission to intensive care, she might have done better and got out quicker. So all of these factors had an impact. And again, in the interest of time, I'm going to shorten this. This is what she needed: a conversation with her goals in mind and the opportunity not to be missed. And the final person I'm going to talk about is Eileen. Eileen was in her 70s. She had dementia which was progressing, and she lived in residential care. She had diabetes, atrial fibrillation and hypertension, and she was on warfarin. One day, Eileen got worse and became confused, so the rest home sent her to the emergency department. She became unconscious, and a CT scan showed that she had a large intracerebral bleed. There was a conversation with her power of attorney, and the consensus was that she should receive supportive care, not brain surgery, not transfer to Wellington, not intensive care management and intubation, but supportive care. And she was transferred back to the care home, where she died 4 days later. Now, why was this possible? Why did this happen? Because her power of attorney was aware of her wishes. There was capacity between the team and the family for that conversation, and there was the resource at the care home to get her back there, which is where she wanted to be. She had person-centered care. The reason she had this is because she had a health professional in the family, and that was me. This should not have to rely on whether you have a palliative care physician as your daughter-in-law. Okay? That's why I'm sharing this story with you. If I had been a farmer or, I don't know, a nail technician, any other profession, would I have had this conversation with this outcome for this lady? And I'm very thankful that I was able to, at the time, have that conversation, and she got the outcome she needed. So that's what she had. Ironically, we're going away next year, and we were planning to have this conversation with her GP in about 3 weeks from now. So it was not quite agreed with primary care. Anyhow, so I'm going to just leave you with some questions to consider. When we're thinking about goals of care and not missing opportunities, we need to think about with illness what's reversible, what's reasonable, and our definition of that might be different from the patient and the family. Who should be involved in the conversations? When should they happen? And is there time to have that conversation now? Thank you.